Good afternoon, everyone. Thank you for the invitation. Thank you for the introduction. When I was first looking at the program this afternoon and I saw the two kind of parallel sessions going at the same time, I thought we'll have probably 10 people in the audience. So I'm really impressed by the number of people who are here. Thank you for being here with us. I'm going to address a topic that I've, in fact, addressed in this setting before, and the reason we keep repeating it and they keep asking me to talk about it again, it is because a pertinent topic that is important to every single obstetrician and gynecologist, and in fact, every single primary care provider. And with the time limitation that we have, I'm not going to be able to address all the issues related to an adnexal mass, but what I'm going to try to do is cover some of the important critical points or questions that you might face as a general obstetrician and gynecologist taking care of young or older women who present with adnexal masses. So this is just general statistics. Individual lifetime risk for any ovarian neoplasm is about 5 to 7%, and the individual lifetime for ovarian cancer in the general population is 1.7%. These are the US statistics, so these vary by populations that might be higher or lower. What is most important and what most of us know that the risk of ovarian malignancy or neoplasm, irrespective of what the histology we're talking about, is more dependent on age. So you have a much higher risk of malignancy when you are looking at a premenarchal young girl who presents with an adnexal mass, or in a postmenopausal woman who presents with an adnexal mass. In the younger population, in the reproductive age group, these adnexal masses most of the time tend to be benign in nature, whether they are a functional cyst, whether they are endometriosis, or whether they are a mature cystic teratoma. So I'm first going to talk a little bit about malignant ovarian germ cell tumors. And the reason I chose that topic, because for each one of you, you might be faced at some time by being consulted to the emergency department with a young woman presenting with acute abdominal pain, or a pelvic mass, or abnormal bleeding, and they do an ultrasound on that young woman and they find that she has an adnexal mass. And you kind of tend to need to decide what to do and what to operate and what to do with these women. And a lot of times, some of you might think, well, this is a unilateral adnexal mass, and the reality is probably going to be benign. Well, this study shows that the majority of ovarian malignant germ cell tumors in the young patients are unilateral. So the fact that you have a unilateral adnexal mass in a young woman does not make it necessarily a benign condition. The other thing that's important to remember, that even when adnexal masses are unilateral, and even if you do an advanced test radiologic imaging, such as a CT scan or MRI, you're still going to miss sometimes lymph node metastasis in those patients. The risk of malignancy becomes much more prevalent than in the young woman. And these are important things to remember. However, it does not mean that every adnexal mass in the postmenopausal woman is a malignant mass. Two most common histologies in a postmenopausal woman when you are looking at adnexal masses. In fact, the most common histology when you are looking at adnexal masses in postmenopausal women is going to be an epithelial ovarian tumor. And an epithelial ovarian tumor is usually a continuum from a benign epithelial ovarian tumor that we call a cystadenoma to a borderline tumor into a malignant tumor that we call epithelial cystadenocarcinoma, and there are different histologies in that respect. People always ask about CA125. One thing I want to kind of remind everyone, CA125 is a good test when you are dealing with an adnexal mass in the postmenopausal woman. CA125 is not a screen for ovarian cancer. It should not be used in the general population to screen for ovarian cancer. CA125 is not a good discriminatory test in the younger woman, because there are so many conditions that result in elevated CA125 in the young woman, including endometriosis, fibroid, inflammation, infection, and other conditions. So we need to have a problem, we need to kind of make sure that we keep that in mind in that respect. Okay, looking at this, so looking here, when you look at the sensitivity of CA125, you have the sensitivity of CA125 to look at adnexal masses is not a high sensitivity. It's only 60 to 90%. More importantly, the positive predictive value is about 35 to 91%. So you have a very wide range when you are using CA125 in the whole population. But what I want you to remember, an elevated CA125 in a postmenopausal woman is almost a certain diagnosis of a malignancy. So when you have an elevated CA125 in somebody who is 55 or 60, This is not benign. This is not fibroid. This is not endometriosis usually. And I really urge you to seek help or to consult your colleague who deals with these things before you take the patient to surgery. There is a test that has been developed in the United States and at the present time is very commonly used, in fact, by our obstetrician and gynecologist, which is OVA1. Because of the fact that CA125 by itself is not sufficiently sensitive and specific test to manage adnexal masses, they came up with a combination of blood testing, including CA125, transferrin, transerythrin, apolipoprotein A1. And these are tests that usually ordered as one test. That's called OVA1. And you send usually the blood to a lab to be tested. And they use a software. Based on that software, they come up with a risk score index. And the risk score index is based on age. So in the premenopausal woman, if the OVA1 is less than 5, the risk of malignancy tends to be significantly low. If it is higher than 5, that you need to be concerned about a malignancy. In the postmenopausal woman, that cutoff point is 4.4. To give you an example, in fact, just last week before I traveled overseas, I got a referral of a 72-year-old woman who had an OVA1 ordered by her physician with a complex adnexal mass. It came back at that time at 6.2. I operated on that patient just a couple of days after I saw her, turned out to have a high-grade serous adenocarcinoma and had metastasis to the multiple lymph nodes. So again, to remind you that some of these tests are important sometimes and helpful in kind of making decision. The speaker before me, Professor Guillaume, just gave a great really presentation on ovaries, and I was really impressed by the 3D images that they've had. These are very old images, but ultrasound is really an excellent test to evaluate the ovaries, irrespective of what age. And I really urge you that you kind of continue to increase your skills using ultrasound, irrespective of what technology, because it is the first test to use in women's imaging. When you look at an ultrasound, it's important to look not only at the size of the adnexa that you are looking at, but also the consistency if there is any cyst on that adnexa, on the ovary, or on the fallopian tube. Determine whether you are looking at a simple cyst versus a complex cyst. Determine how thick are the wall of that cyst. Sometimes blood flow through the wall of those cysts make a difference. And determine whether there is any solid component. All of these things become important in determining whether what you are looking at is a neoplastic process or a benign process. And when we are looking at a neoplastic process, we are most concerned about cancer or malignancy. So let's go to that young patient whom you operated on. You got called to the emergency department. She has an acute abdominal pain. You do an ultrasound. You find that she has a 7-centimeter complex adnexal mass. She is having acute pain, and you need to take her to the operating room. You open the patient up, and you see, something that you don't like. It looks hemorrhagic, some solid component, some cystic component. What should you do at that time? The best thing to do at that time, if the ovary is not salvageable, is just take that ovary out, look around. If there is something that looks abnormal, take a biopsy of it and get out of there. Do not take the other ovary out. Do not biopsy the other ovary. Do not do blind biopsies. Because the reality is that with ovarian germ cell tumors, number one, they are very chemosensitive, and even if the patients have metastatic disease, you can cure them with chemotherapy. Number two, fertility preservation is a must in this younger population. So in these patients, you don't really need to go through any radical thing. Even if you have a pathologist in-house who can give you an immediate diagnosis and they say, we suspect that you are dealing with a malignancy or malignant ovarian germ cell tumor, you should not take the other ovary out. In the old days, people used to biopsy the other ovaries empirically. Do not biopsy the other ovary unless you see something abnormal on the other ovary. This is a study showing survival rates of patients who had stage 1 ovarian germ cell tumors and dysgerminoma. And all what it shows you, this is time. This is 250 months here. And here you are looking at, it's not showing here. So on the left-hand side, you are looking at overall survival. On the right-hand side, it's just for dysgerminoma. And when you are looking at these survival curves, the x-axis is month. So you are looking at 250 months. So this is 20 years, essentially. On the y-axis, you are looking at the proportion of patients who are surviving. So you want to have 100% or 1.0 survival. And what this shows you that patients with ovarian germ cell tumors have an excellent survival. I mean, all of them live. In the old days, in the 50s and 60s, the mortality rate from ovarian germ cell tumors used to be 50 and 60%. Now you have a survival rate of about 100%. So a very, very high survival rate in these patients. What is also important in this patient population that these women, 60 to 90% of them will resume menstruation depending on their age. And this is why, again, it is very important to be conservative when you approach these patients and try to preserve the other ovary and uterus and not do a full hysterectomy or forectomy. We're going to shift gear a little bit now and talk about epithelial ovarian cancers. I'm not going to go into details because we are going to be talking more about general approaches to these tumors, not big tumor debulkings and chemotherapy. What is most important at the present time is to kind of know that with epithelial ovarian cancer at the present time, most people have divided them into two big classes of epithelial ovarian cancers. One that is called type 1 and the other one that's called type 2. Type 1 will include the low-grade ovarian tumors, epithelial ovarian tumor, mucinous, clear cell, and malignant Brenner tumor. The type 2 include high-grade serous carcinoma, high-grade endometrioid adenocarcinoma, and malignant mixed cell tumors. Why is that differentiation important? Because it's believed that these two different kinds of epithelial ovarian cancers follow a different pathologic path. So it is believed that really the type 1 follow a path of a benign, borderline, low-grade serous carcinomas. Versus the high-grade carcinomas, it is felt that many of them might be arising at the present time in the fallopian tube. So there is a lot of data at the present time to suggest that a significant number, not all, but a significant number of the high-grade serous ovarian carcinoma might have started in the fallopian tube, and by the time that you start seeing an adnexal mass, these tumors are already advanced. And this is why it is believed at the present time that 60 to 70% of epithelial ovarian cancers are diagnosed in advanced stage disease, because it's felt by the time you are diagnosing them, you are seeing something on the ovary. Those cancer cells that are from the fallopian tube has already dropped not only on the ovary, but within the whole peritoneal surfaces. And this is why also there is more and more push at the present time that at the time of hysterectomy, if the patient is preserving her ovaries, to go ahead and take the fallopian tubes out. There are also some recommendation that in patients who are undergoing tubal ligation at the present time as part of contraception, to do a prophylactic salpingectomy in these patients because of the theories about the origin of epithelial ovarian cancer. Borderline ovarian tumors, I know that there is going to be a talk tomorrow specifically about borderline ovarian tumors, but since some of you might be in a parallel session, I wanted to bring this to your attention. So similar to malignant ovarian germ cell tumors, borderline ovarian tumors have a very indolent course. They also can impact young patients. Accordingly, it is important to be conservative in their treatment rather than being radical in their treatment. So if they are affecting one ovary, we try to preserve the other ovary. If they are affecting two ovaries, we try to take one ovary and do cystectomy on the other ovary so that we can preserve the fertility on these patients and preserve also hormonal production, because putting a young woman through menopause, we know that have significant long-term risk from a cardiac perspective, from an osteoporosis perspective, from bone fracture perspective. So this is why it is very important to keep things in mind in that respect. And in this slide here, you see in the second point that there is a really very low risk of lethal recurrence with borderline ovarian tumor. It is only about 0.5%. And there is a significant spontaneous pregnancy rate in these women. So this is why when you are dealing with borderline ovarian tumor, it is more to have a conservative mindset when you are doing surgery than to have a radical surgical approach. This is a typical high-grade serous carcinoma. As we said, we are believing now that some of these might be arising from the fallopian tube. We know that at the present time, 10 to 15% of these, at least based on some Western data, whether this is US-driven data or some of European-driven data, have some genetic predisposition where they come from families who have BRCA1 and BRCA2 mutation. What is also interesting that we know that there are certain genetic predispositions other than BRCA1 and BRCA2. And the important thing to remember that especially that you have a significant risk of breast cancer in the population here at a younger age, to start thinking about genetic counseling and screening of these families. So although we don't have a high frequency or prevalence of BRCA1, BRCA2 mutation at the present time that we know of at least, or founder mutations in our population here, but we need to kind of keep an eye on that because we have significant intermarriages or generations of significant intermarriages in the past. Epithelial ovarian cancer is rare in the younger population, and in these patients, still the treatment tends to be surgery. Unlike with ovarian malignant germ cell tumors and unlike with low-grade or borderline tumors, most of the time you need to do, most of these patients have advanced stage disease and you need to do radical surgery on them in order to help them and cure them. Is it appropriate to aspirate an ovarian cyst? Well, it all depends what you are aspirating it for. If you're aspirating it for to kind of relieve symptoms for a patient, and you don't think that this is a malignant disease that you are dealing with, sure, you can aspirate the ovarian cyst. However, if you are doing it for a diagnostic purpose, one, aspiration of an ovarian cyst has a very, very low accuracy and pickup rate to kind of diagnose what you are dealing with, number one. Number two, if it is a serous cystadenoma, so if it's an epithelial lesion, chances that it's going to kind of recollect on you again, or if it's an inclusion cyst or mesothelial cyst, if you aspirate it most of the time, it's going to recollect. So this is why I said it depends on what you are kind of aiming to do it. What I would suggest is the thing that you don't want to do is aspirate a cyst in a complex mass to say, well, I want to determine whether there is cancer. Because one, by doing this, there is a significant risk that you've spilled into the abdomen the cancer cells that are into the ovary if they are there. And number two is that it might give you a false sense of reassurance because, as I said, the accuracy rate of cytology on that ovarian cyst is not very high. So this is why it is important before you make that decision to kind of determine what are you aspirating the ovarian cyst for. Role of laparoscopy. Is there a role of laparoscopy for management of adnexal masses? Absolutely, especially in the younger population. The majority of the younger population that whom we take care of, we manage their ovarian masses through a laparoscopic approach. It's minimally invasive. It's associated with a better recovery, less pain, shorter stay in the hospital, less complications, as long as we are not concerned that this is a malignancy. Because if we are concerned that this is a malignancy, then it's a totally different story. People say, well, why don't you kind of, if you are concerned that this is a malignancy, let's take it out, determine what it is, and make a determination what to do afterwards. Because the data is very, very clear that if you have a malignancy that you are dealing with, and you do a first surgery to take the ovary, and then you come back 2 or 3 weeks or 4 weeks later to kind of perform or complete the surgery, you've impacted the prognosis of these patients in a negative fashion. So this is why if you are concerned about a malignancy, try to make sure that you have all the ducks in a row as far as what's the best surgical management of this patient at that time. If you're not concerned about a malignancy, if your index of suspicion is low, absolutely, a laparoscopic approach to remove an adnexal mass, whether you are doing an oophorectomy, a cystectomy, a salpingectomy, is the absolute way to go. So, principles for surgical management of an adnexal mass. Always prepare the patient for the appropriate surgery. And when it comes to pre-op counseling, I put here for GI prep and GI workup, and whatever else you need to do in those patients. If you need extra testing before, if you need extra radiologic imaging, please make sure that you do this. If you are suspicious of an adnexal malignancy, please avoid rupture into the abdomen because it can make the prognosis worse in these patients. I said here obtain a frozen section if suspicious. I fully understand that this might not be available in many of the hospitals you might be operating in, or sometimes you might be operating doing a surgery in an emergency status at night. You won't have the pathologist there. So this is something that I would suggest or recommend in situations where you have it. And this is also where I would suggest if you have a suspicious adnexal mass and you want to operate on them electively, talk to your pathologist in your hospital ahead of time and see whether they will be able to give you a frozen section at that time. As we said, try to do all necessary procedures at the same time. Taking a patient twice or 3 times for one problem is not a good thing to do. And try to preserve fertility in younger patients. Situations where you need to kind of think about malignancy, as we said, premenoptical girl. So if you have somebody who is 7 or 8 years old and you've consulted as a gynecologist on this woman, and if this young lady has an adnexal mass that is solid and or complex in nature, consider a malignancy, because these women can have germ cell tumors or can have other malignancies that are, that can arise in the pelvis or abdomen. definitely in the postmenopausal woman, as we said, elevated CA125 in a postmenopausal woman is a risk, is essentially cancer until proven otherwise. So about 10 years ago, the American College of OBGYN, as well as Society of Gynecologic Oncology, came up with certain recommendations when to involve a gynecologic cancer specialist in the care of women with adnexal masses. In the premenopausal woman, they said if you have a CA125 that's over 200. Having said that, I want to kind of caution you that if you have a CA125, even in 300 and 400, don't tell the patient in a premenopausal woman you have a malignancy, because I can tell you I've seen cases of endometriosis when I've seen CA125s in the 800, 900, and 1,000. It is not common, but it does happen. So that in a young woman, do not scare her and say this is definitely cancer until you have a pathologic diagnosis. Obviously, if you have on a CAT scan evidence of masses other than the pelvic mass, this should be concerning. And as we said, family history of of breast or ovarian cancer. In the postmenopausal women, index of suspicion should be much higher in these patients. Anytime you have an elevated CA125, get a gynecologic, a specialist in gynecologic cancer involved. If you have ascites, presence of ascites is malignancy until proven otherwise in these patients. And again, a family history of epithelial ovarian cancer. Thank you for your attention. I'll stop here and I'll be happy to take questions later.